Right. So intercostal tubes, T-tubes, catheters, and drains. First, we will go with the definition. So a surgical drain is any device that allows you to remove fluid or gas from a wound or a body cavity, right? You would have seen these being used in the past. You'll see plenty of them in the future. There will be various types, right? This is just a broad overview of what they are like, what they do, and an overview of some specific types of drains. So basically what a drain does is it lets fluid or gas come out either of a wound or a body cavity. This can be for various reasons. It might be that what's inside is infected material like pus. It might be because what is collecting inside is dangerous or problematic. For example, if air or fluid collects inside the thoracic cavity, you can cause the lung to collapse and the patient can have a respiratory problem developing, right? You can have a pneumothorax or a pleural effusion, or if it's blood, we may call it a hemothorax. So those things can cause problems in breathing. So the fluid has to come out. Sometimes the patient can't pass urine, so they need to have a drain inserted into the bladder to drain the urine out. Sometimes we have done a surgery, we are worried about bleeding afterwards, so we put a drain in. Sometimes the patient can pass urine, but we want to measure the urine output very accurately, right? So sometimes we might put a drain in just to make sure that the input of the patient and the output of the patient can be assessed properly, to check whether the patient is well balanced, dehydrated, things like that. So there are many reasons for inserting drains. You can just, if you like, one of the bits of assignments that you have is to make a list of reasons that we have to insert drains. Then we go to how drains are classified. The simplest way of classifying drains is as open or closed systems. An open system is where whatever comes out of the drain is exposed to the external environment. So sterility is sometimes a problem in open drains, right? Closed systems are where whatever comes out gets collected into a bag or a bottle or something like that, and the whole system is not exposed to the external environment. So sterility is better with closed drain systems than with open drains, right? And closed systems, sometimes we can apply a bit of suction also to let fluid or gas come out. Sometimes we don't apply suction. So closed systems could be suction or non-suction, and you have open and closed drain systems. When we talk about a few examples, you need to think about which of these they actually are. Then we'll go to a few examples of these drains. One of the simplest drains to let things come out of wounds that people used for a long time was just a piece of cloth, right? Can anyone try and work out how a piece of cloth put into a wound lets things come out? What's the principle there? Anyone? How would it come out?
Absorption.
Absorption. How does it move through? In the same way that it does in a wick. Okay, here the oil flows up the wick. How? Capillary action. Okay, so in the same way, from whatever cavity, fluid can move up with capillary action. So what you can see here is a very common process that's done in patients who have a subcutaneous infection. This is an abscess. Now look at this cavity. This is the abscess cavity, right? What will an abscess cavity be lined by? Anyone? You've done your
fibrous tissue.
Yeah, there is going to be fibrous tissue. What do we call that? The wall of an abscess cavity. It's given a specific name. It's called a pyogenic membrane, right? So what causes fibrosis? What is the tissue that undergoes fibrosis? There is a tissue that you get before you get fibrous tissue. What's that? Anyone? From basic path? It is associated with chronic inflammation. You've done your basic pathology, isn't it? Yes or no?
Yes, sir.
So what's the kind of very vascular tissue full of capillaries that you get after?
Granulation tissue.
Yeah, granulation tissue. It's granulation tissue that turns into fibrous tissue later on. So this pyogenic membrane is full of granulation tissue. So when you cut the wall of the abscess, let all this pus come out. This wall is then lined with granulation tissue and fibrous tissue. Now, this is the opening, right? Now, we take out the pus, we just wipe away the pyogenic membrane. Now you have this cavity. And this is all that there is at the top, a small opening of the skin. Now, the moment you do that, the moment you let the pus out of any abscess, two processes start at the same time, right? One is there is a hole in the skin, so epithelialization will try to bridge this gap from here to here. Did you understand that? Right? From here to here, epithelium will start to grow, and this will try to cover the skin opening. The other thing that's going to start to happen is this abscess cavity, which is lined by granulation tissue, the granulation tissue will also slowly start to grow from outside to inwards to try and fill this empty pot. Right. If we want the abscess to drain completely, which of these two processes do we want to happen first? The epithelialization to complete, or for the internal granulation to fill the cavity? Which one do we want to win the race?
Internal granulation.
Yes, because if the epithelialization covers this opening before the internal granulation finishes, if you are left with, let's say, this is all the granulation that has occurred, right? So this is all the granulation that has occurred, right? And this bit of the cavity is left, right? And the epithelialization has covered the bridge. Then what happens is you have another abscess there and you have a recurrence of the abscess. So we want the cavity to fill up before the skin closes. That is a very basic principle of draining any abscess, right? And you will find this a lot in surgery. Now, if it's an area where cosmesis is not a problem, like say a buttock, then the way we get rid of this problem is by making a huge cut at the top so that there is a very big opening. So we know pretty well that the epithelialization is not going to win the race until the whole cavity fills. But we can't do that all the time. If the cavity is very deep, right, let's say it's an abscess in the liver or deep inside the retroperitoneal structures, then we can't make a huge opening to the skin, right? Or sometimes the cavity is in a place like the face or the arm where you don't want to have a very bad cosmetic outcome by making a huge cut to the skin. That is where a drain becomes very useful. So when you put a piece of gauze like this into the cavity so that it stays like this, it does two things. One, it lets all the fluid come out, right, through capillary action, and we can slowly, as this cavity becomes smaller and smaller, we can pull this out little by little. Understood? At the same time, it also keeps this cavity from closing because we have put something across it. So a wick that we put, a little piece of gauze that we put after an IND of incision and drainage of a skin abscess is one of the simplest drains that we use. And it has two functions, letting the fluid out and keeping the hole open. And for most internal drains also, that is the reason that we put it in. Keep the hole open and let whatever is there come out. So there are various other drains. Some of them are a bit more advanced than this. We'll talk about a few of them one by one now. Right. So this thing, which looks like one of those asbestos sheets that you find on roofs, is actually called a corrugated rubber drain. Corrugations are these little wavy things that you can see on the cross section, which go like this. So anything that is shaped like this, we call corrugated. So we call asbestos sheets corrugated sheets. Those old takarang sheets were called corrugated metal sheets. In the same way, this is called a corrugated rubber drain, right? So corrugated drains are used for the same thing. Now this whole drain is not put in. These come in sheets like this. What we do is we make a cut like this, right? And cut out a long strip for the length that we need. So we'll end up with a long strip like this, right? And this strip has corrugations along it, okay? It's got corrugations along it, and that gives a wider surface area, and it also gives channels for fluid to flow around. So this is not similar. This doesn't have capillary action, unlike the previous one, but it's also a different kind of drain. Then we have this kind of suction drain, right? As you can see, this bit of the drain is like an accordion, right? You can apply suction by removing the bottle at this point and then squishing it like this. You can just press the bottle like this, right? Squish it and then connect it to this, and then there's a suction vacuum there. And the other side of the drain over here is inserted into the body cavity, right? Or into a wound or whatever, and then it will actively suck out secretions. We tend to put suction drains into subcutaneous incisions. Sometimes when we make a cut in the skin and subcutaneous tissue, for example, in things like mastectomies or abdominal wall operations, right? Then we have to cut the subcutaneous tissue quite wide like this. And then underneath that, we have, say, the abdominal wall muscles or whatever, like this. Okay. So we have quite a large cavity then, which gets created here when we make that kind of cut and we dissect between the abdominal wall and here. Now, if we let that kind of thing just wait without putting suction, and if we just close the skin here at the end, we get serous fluid accumulating as an exudate in this area. We call that a seroma, right? So you can have seroma formation sometimes when you make subcutaneous large incisions and skin flaps. So to prevent seromas from forming, we can put a suction drain into this space and close. So that's another example of the kind of drains that we insert. Right. So this is again a drain that has been inserted into the abdominal cavity. It's going into the peritoneum. So whatever is there in the peritoneal cavity, maybe it's pus, maybe it's blood, will drain out. We tend to not put suction drains into the peritoneal cavity. So go through the ward today after the class and see whether there are any patients in ward 1, ward 2, ward 20, 21 who have various kinds of drains inserted. I'm sure you will find plenty of patients who have abdominal drains inserted. Once you have an abdominal, find someone with an abdominal drain, discuss among yourselves. Why has this drain been inserted? What has come out of the drain? How much has come out? Right? Is there more today than yesterday? Right? Is the daily trend of the drain increasing or decreasing? Do you think we can take the drain out now? So those are important questions that you will have to find answers to. Right. So this is another kind of external drain, which is done when there is a block in the biliary system. This is called an external biliary drain. It's a very specific kind of drain. We insert this under ultrasound guidance or radiological guidance, right? Through the skin, through the liver, into the bile duct. If there is a block, like you can see distally here, this will let the bile drain out. And if the patient has obstructive jaundice, then the obstructive jaundice will get relieved, right? So you have done your physiology. What are the complications of obstructive jaundice? Anyone? What happens to the patients? What are the problems physiologically that a patient has when they have obstructive jaundice?
cholangitis and cholecystitis.
Yeah, they can get cholangitis because bile can collect here and cause infection. These are systems that are designed to drain. If there is no drainage, if there's accumulation, then you can have infection of the biliary tree, which we call cholangitis. Good. What else can happen to patients?
Liver failure.
They can get liver failure, yes, because of the obstruction and the liver not being able to work well. What else will happen to them?
Mucocele in the gallbladder.
Yeah, sometimes they can have mucus collecting also if it goes on for a long time. They'll probably get cholangitis and cholecystitis before that happens. Anything else? Now, bile is not coming into the intestine, no? So think about what will happen.
Bleeding manifestation due to vitamin K deficiency.
Good. So they will get bleeding manifestation. Why will they get vitamin K deficiency?
Because vitamin K is fat soluble vitamin. Therefore, for absorption of vitamin K, bile is needed. Bile does the emulsification and helps to form the fat, help to absorb the fat soluble vitamins and the fat. Therefore, when bile secretion is impaired, the vitamin K absorption is impaired. Vitamin K is needed for the glycosylation of the clotting factor 2, 7, 9, and 10. Therefore, those clotting factors are affected. This leads to bleeding tendency.
Good, right. So if you put an external biliary drain into these patients, will the cholangitis settle? Anyone? It's probably going to settle because the obstruction to the bile is now relieved and the bile will drain out with whatever infection there is. Will the liver failure settle?
Yes.
Yeah, that will settle. Will the bleeding manifestation settle?
No.
No.
Good. So that's an important thing to remember, right? So external draining of the bile will let the infection settle. It will let a liver failure settle, all those things, right? So the liver will start to work again. But the fat soluble vitamin deficiency is not sorted out by this. So we have to give these patients intravenous vitamin K and things if they are on an external biliary drain, right? Because we can't replace the vitamin K if this is draining externally. Okay, right. So next we are going to talk about another type of specific drain. This is the intercostal drain. Now the intercostal drain tube is just this little bit which comes from the lung up to here. Does anyone know what this bottle is called? You might have been taught about it in the anatomy. What's this bottle called? This is called a underwater seal. Now, this is a very specific type of drain that is put when patients have a fluid or air collection in their thoracic cavity. The reason is, if we just put a direct tube to drain out the blood or pus or fluid or gas out, then that will affect ventilation. Because for ventilation to occur efficiently, we need the patient to have a negative intrapleural pressure in this area. So if this drain connects directly to the external environment from here, right, then every breath that they take, air will get air or whatever will get sucked in from this, right? And then the lung will not expand, right? So when you have a fluid or gas collection in the thoracic cavity, you can't put a normal drain. You have to put a specific kind of drain called an intercostal drain and an underwater seal, right? And the principle is really simple. This drain goes like this and is put into sterile water. And the bottle is kept at atmospheric pressure by this other tube that is in the bottle, which connects to the atmosphere. Now, when the patient takes a deep breath, right, a bit of fluid gets sucked up this way. But when fluid starts to get sucked up, there is a water column developing, and then there is a negative pressure pulling that way, right? And this stays at environmental pressure, but you get a vacuum created in this space over here by this sucking, which means that the lung will not become, the pleural cavity will not have zero pressure. With this seal lets a negative intrapleural pressure to develop so that expansion occurs. But if there's any fluid or something like that, right, in this lung, right, if there's any fluid or something accumulating here, it can always come this way and get mixed with the fluid over here. Or if there is any gas, then it will start to bubble out. So an intercostal drain is always connected via an underwater seal. Now, if this tubing system is working well, is there anything that you will notice when the patient takes a breath in and out? Anyone?
Water column.
Good.
Water column.
To the water column will go this way when you inhale, and it will go this way when you exhale, right? We call that, that is a very important word to remember, that is called the swing, right? That is called the swinging of intercostal tube. So whenever you have an intercostal tube, one very important thing to check to see whether the tube is functioning well is whether it's swinging. If the tube is not swinging, that's a problem. That means that somewhere inside, maybe here, right, or somewhere like that, there's a block. Something has got accumulated here. Maybe it's pus, maybe it's a clot of blood, maybe it's a bit of tumor or whatever, and the tube is not doing its job. And if the tube is not doing its job, that means that over here, fluid or whatever is now accumulated. So whenever a patient has an intercostal tube, you must check whether there's a swing. If it was inserted to control a pneumothorax, there would also be bubbling, which is a another thing that you have to look for. You won't expect bubbling if it was inserted for fluid, but if it was inserted for gas, there should be bubbling as well. So whether it's swinging or bubbling is a very important thing that you have to check when a patient has an intercostal tube insertion, right? Okay, so we are going to stop sharing for a moment so that I can show you the intercostal tube yeah, can you, yeah, okay, so this, what you can see here is a sterile pack that contains an intercostal tube. So you have to work out the size of these tubes when they come, and the details of the tube will be on the other side, right? The date of expiry, right, will be over here. The date of manufacture and the date of expiry will be here. And here you will see the size of the tube. It says 28 FG. Does anyone know what FG means? Right. FG stands for French gauge. There are two ways in which instrument diameters in our ward are assessed. One is by gauge, right? This is a needle, right? And in this hypodermic needle, you will find that now this one has a green tip, but there will be various other needle sizes. The size of the needle will be color coded according to the color over here. And when the diameter of the needle becomes larger, its gauge becomes smaller. So a large gauge needle is a narrow one. A small gauge needle is a wide one. So for things like needles, cannulas, you will need to know what the color coding means and what the diameters are, because you will need one type of needle for venipuncture, another type of needle to inject subcutaneous insulin in a patient, another type of needle to draw blood, right? So the type of needles that you need, the type of cannulas that you need are color coded. So they are according to gauge. FG stands for French gauge. Things like chest drain tubes, right? And then another type of tube that I'm going to show you later on, right? Which is a catheter tube, right? As you can see here, it says 18 CHFR. The FR again stands for French gauge. Some types of tubes are sized according to French gauge. French gauge, I'm afraid it's a bit confusing. French gauge is different from normal gauge. When the French gauge of a tube goes up, the tube size goes up. When the gauge of a tube goes up, the tube size goes down. So if a tube is, some tubes are sized according to French gauge, some other tubes are sized according to gauge. Needles are usually sized according to gauge, cannulas according to gauge. Chest drain tubes, NG nasogastric tubes, which you will be talking about with someone else later on, catheters and things, they are going to be assessed according to French gauge. So this tube is a 28 French gauge tube. And this says that 28 French gauge also means 9.3 millimeters. So now this tube is sterile. I'm going to show you how a sterile tube should be opened. These tubes have an outer pack and an inner pack. Usually there's someone who has sterile gloves on, who is waiting for this tube to be sent to you. So you have an outer pack, which is this polythene and this. You just open it up like that. The inner pack comes like that. You just fold like that and you give the person there the inner pack. And when it's sterile, the person wearing the sterile gloves will take out the inner pack by themselves. So now I'm going to break sterility and take this out. Now this is the inner pack. In case you have broken sterility, the inner pack also has the same system where you have to do that. So one of the first things that you will have to learn in ward is when someone is doing a sterile procedure and they want a needle, right? Or they want a syringe, right? How to open the tube like this and give. So this is the way that you open it in a sterile manner. Haven't touched the inside at all, and you can offer it to them like that and they will pick it up. Here I'm going to pick it up and take it out. So this is a intercostal drain tube. Some of these have a metal stillet that goes through them. This one, a sharp stillet, right? We are not going to, we commonly don't use these when we insert tubes. We take the stillet out and throw it away. Someone takes it to clean their sink with usually, right? We don't use it. So this is the tube. It's a flexible tube, right? And you will see that it is numbered with numbers of centimeters here, 5 centimeters, 10 centimeters, and it's got a hole at the tip and it's got a few side holes as well. So you need to know how this gets inserted and where. Have you heard of the concept called a safe triangle in inserting a chest drain? Anyone in anatomy? Has that been taught to you?
Yes, sir.
Okay. Does anyone know the margins of the safe triangle? That's very important in inserting a chest drain. What are we trying to avoid?
Margins are mid-axillary line,
Good.
anterior axillary line,
Yes.
and fifth intercostal space.
Yeah. So the reason for those three are the structures that are bounded by them. If you insert the tube anterior to the anterior axillary line, then you will have to go through the pectoralis major, and in the females, the breast tissue also. So you must always stay behind the anterior axillary line, right? If you try to press directly at the chest beyond the mid-axillary line, you will damage the long thoracic nerve, which is coming down towards your serratus anterior, which goes roughly just behind the mid-axillary line. So a tube that goes in through the mid-axillary line or behind it can damage that. So we have to stay behind the anterior axillary line to avoid the pectoralis major and in front of the mid-axillary line. Why fifth intercostal space? What happens if we go beyond that, below that? Anyone?
Liver is there.
Yes, good. The liver, and more than the liver, the diaphragm. You can sometimes pierce the diaphragm because below the dome of the diaphragm on the right side and the left side are slightly different. On the right side, it's at the fifth rib. On the left side, it's at the fifth intercostal space, a little lower. Okay. So if we can stay at the upper border of the fifth rib, then on both sides we are safe. So instead of fifth intercostal space, if we can stay at the upper border of the fifth rib on both sides, then we are pretty sure that we are higher than the highest point of the diaphragm, the two domes. So that's why we stay above at the upper border of the fifth rib. So that is a safe triangle, and we usually insert the intercostal tube there. You will need to know the structures that you pierce when you go through, what kind of anesthesia is given, right? What kind of instruments are needed. So if you do see an intercostal tube, go through it, go through the BHT and see whether the patient's procedure notes are there. Ask someone in the ward how an intercostal tube is inserted and try to make a list of equipment that you need to insert an intercostal tube. Okay, so this is an important thing to know about. And also you need to know about when a tube is in the ward, when a patient with a tube is in the ward, what things you have to look for, right? So having said that, we'll go back to our class, right? Can you see this image again?
Yes, sir.
Okay. The next thing is another type of biliary drain, which is inserted in a different kind of instance. This is called a T-tube. It's called a T-tube because it is T-shaped, right? I'm not going to open it up, but I have a T-tube with me as well. I'll show it to you after we work out what this is done for. Now, T-tubes are inserted when we have a stone or something in the common bile duct, and we have done a surgery called a common bile duct exploration to get rid of the stone. Once we have removed the stone, we can close the bile duct and come out. The problem is we are not always sure whether we have cleared all the stones. Now, by some bad luck, if we haven't cleared all the stones, then what's going to happen is a residual stone is going to block here, and the bile will start to fill up inside the bile duct. Okay, the bile will start to fill up inside the bile duct, right? And what will happen to the bile? It will try to leak out. And where will it try to leak out from? From the place where we made the incision in the bile duct to get the stone. If that happens, the patient can end up with what's called biliary peritonitis, and that's a dangerous condition. To avoid that problem, what we do is we insert a T-shaped tube. This part of the T stays in the bile duct. This part comes out. But there is a hollow from here to here also. So this is a rather clever device, which means that if there is no block, the bile will flow down directly. If there is a block, right, instead of biliary peritonitis occurring, the bile will safely come out outside the abdomen also. Okay, so it does both those things. After a few days, after surgery, if we see that the amount of bile that is coming out from here is progressively getting lower, that means that we are pretty sure that the bile is now flowing downwards, right? Then we can remove this tube. Before removing the tube, is there anything else that we can do to make sure that there is no blocked stone remaining in the tube? Anyone?
Cholangiography.
Good. We can give some contrast from the T-tube, right? And then take an X-ray and do what is called a T-tube cholangiogram. Okay. So there are ways, anytime that you insert dye into the biliary tree, it's a cholangiogram. Previously, a couple of slides ago, you saw a cholangiogram that was done for an external biliary drain like this. Okay, so that is also a type of cholangiogram, right? But here what you're seeing is what's called a T-tube cholangiogram, which is done when a T-tube is inserted. And if you don't see any stones or anything on the T-tube cholangiogram, then you can just pull the tube out. For a few days there will be bile coming from here like a fistula, and then it will also settle and dry up nicely. Right. Then we are going to talk about another important gadget that is used in draining urine, and that is called the Foley's catheter. Okay, so Foley is the person who devised this method of what is called a self-retaining catheter. Okay, a self-retaining catheter is a catheter that you can insert and it will stay inside by itself, right? As you can see here, Foley's catheter also has sizes given here. It's an 18 French catheter, right? And at the other end of the catheter, there is a balloon. When the balloon is inflated, then the catheter can't be pulled out of the bladder. And through this internal lumen, the urine will flow out. So a Foley's catheter is a very clever gadget, which is very commonly used in hospitals, right? You will need to know a lot about a Foley's catheter also. Now, I have a Foley's catheter here with me now, right? And I'll just open it up and show you what it's like. Again, all the information is on this side, right? It tells you that it's a catheter. It tells you what the material is. Can you see what it says there? What is the material that is made of? Anyone? Yeah. What's the material?
Latex, sir.
Yeah, it's made of rubber latex. Catheters made of rubber latex cause a lot of irritation if they are left for a long time. The longest that a latex rubber catheter can stay in the urethra is for about 3 to 4 weeks. If you want it to continue, then you have to change the catheter, right? If not, you have to put a different kind of catheter that stays for longer. Those are called silicone catheters, right? So silicone catheters can stay for up to 3 months. Okay, they don't cause as much irritation, but they're more expensive, right? Again, here it says open here. There is a sign for the kind of peel open that we talked about earlier, and you can open it up like that. And again, you've got a inner tube. I'm going to break sterility now and take this out. So this is the catheter. If you open up the inner tube, you can see that it's the catheter. So from this eye with the side holes, this is the where the tube starts, which comes out of here. So you connect this into the urine bag, and the urine will flow out like this. This is the valve for the balloon. So what I'm going to show you now is with a syringe, right? I'm going to inflate over here, and you will see this balloon over there inflating, right? So the balloon inflates and deflates. What do we usually inject into the balloon? Is it air that we inject into the balloon usually?
No, normal saline.
It's safer if you inject distilled water instead of normal saline, because saline has salt in it. Sometimes a bit of salt can go and get blocked inside this, and you might not be able to deflate the catheter after that. Okay, it's safer if you inject just sterile water into it instead of that. So this is a Foley's catheter. This is an 18 French Foley's catheter. So this is something that you will need to practically learn how to insert into a patient in a sterile manner. That's an important task that you will need to do as an intern and as a doctor. From now on, you need to practice, all of you. By the time you finish your MSGOP, you need to have asked the interns to show you how to insert a catheter in a sterile manner in the ward. The difficult ones are males. Female catheters go in relatively easily. Male catheters, right? The main dangers that you have are that this is a long pathway through the urethra. If you haven't inserted it completely into the bladder and you inflate this balloon, what will happen?
Urethra will rupture.
Exactly. You will cause a urethral rupture to a patient. That's a huge problem, right? Then this needs to be inserted in a very sterile way, right? And the male urethra is longer, so it's a more painful process. You need to anesthetize the male urethra properly, right? So lots of issues are there. You need to learn how to do this very well in order to prevent prevent urethral rupture and prevent putting infection into the patient. So it's not something you will be able to learn clearly in one go. This is something you will have to keep practicing in wards, in theaters when a patient is catheterized before the surgery and things like that. Learn how to catheterize patients, right? That's an important skill you need to know. Right. We'll go back to our presentation. Right. Foley catheters can be of various sizes, right? Some catheters are for pediatric populations. Other catheters are for females and they're shorter. We don't usually have those. And we also have catheters that are called three-way catheters. where instead of just the channel for the balloon and the channel for the urine to come out, we also have another channel which you can use to irrigate the bladder for a long time. If there is bleeding or something in the bladder, sometimes clots will come and block this. So we have another channel running with saline, which can irrigate the bladder continuously and let it all drain out. So you can have two-way catheters, three-way catheters, large and small catheters. And sometimes in children, in pediatric size catheters, right, to prevent the catheter from bending and making it difficult to insert, you have a little bit of plastic that goes through the catheter, which you have to take out once you insert the catheter, but it makes the catheter a bit stiff during the insertion. You call this a stillet, right? So stillets are sometimes put inside catheters to help them get inserted. And I hope you can see me on the side. Can you see the main screen, or am I still pinned here? What can you see? The large screen, can you see the image, or can you see me?
We can see the image, sir.
Image, okay. I am seen on the small screen, no?
Yes, sir.
Right. So this IC tube that you see, the thing that goes inside this IC tube, this metal bit, this is also called a stillet. It makes it more stiff for insertion. The stillet makes it more unsafe. So IC tubes, we don't insert with a stillet. But a catheter, you might sometimes insert with this little plastic stillet and then pull the stillet out. Okay. Next, okay, here you can see an intercostal tube has been inserted and a chest X-ray shows that the tube is in the right place. Here you can see an intercostal tube has been inserted on one side for a pleural effusion and it has drained this side nicely. The other side, it's still there. Okay, so when a urinary catheter is inserted, this is what it looks like. You can see that the patient has a urine bag connected to their thigh, strapped to their thigh, which they can walk about with, right? Remember, the bag, whether the patient is supine or whether the patient is standing, this bag must always be at a lower level than the catheter. Otherwise, you will send urine in the bag back into the bladder and that will cause infection, right? Then a few words about another type of tube, which is called a stent. If you are interested, find out how these things got their funny name, right? Why are they called stents? Now, this is a ureteric stent. If there's a tumor or a stone or whatever blocking the ureter, you can insert this tube which goes in at one end and comes to the other. It's J-shaped at the two ends to prevent it from migrating upwards or downwards. You call this little bit at the end, right, a pigtail, right? It's given that name after the tail of a pig, which looks like, and this little J-shaped little thing at the end prevents the stent from migrating upwards or downwards. So the ureter is a common place that a stent is commonly inserted. In addition to that, you can have stents in other places also. For example, in blood vessels, right? Coronary arteries, limb arteries, you will see stents sometimes being inserted even in our surgical ward for blood vessels, right? And also, you can insert stents into the bile duct also if there's a block. So remember, the external biliary drain, one big disadvantage with that was that although we could sort out the cholangitis and the liver failure, we couldn't sort out the coagulopathy. But if you insert a stent, right, where this drains it right into the duodenum in the normal way, right, then we might be able to sort out the coagulopathy also in this patient. So that's another kind of drain that you have, stents. Right. So this you will probably have to write down. Our class today, for anyone who had missed it, will be linked to Moodle. If you go to Moodle and check the, I'll send you the link to where this class will be on Moodle so that you can go through this again as well. But I would like it if you write this down also, so that once you go through the ward now, you need to do these things. You need to list out all the drains that you see in the ward. And you need to individually list out 5 uses for a drain. and also generally, regardless of the drain, try to list out complications that you can get with any drain, right? So that assignment is for you guys individually. You will have to do those things individually and submit a little piece of paper with that. Don't waste more than 1/2 sheet per person to list out these things. So that's your individual homework. As a group, you will have to find a patient who has an intercostal tube, right? Find a doctor in the ward, discuss how you would assess any patient with an intercostal tube. This is a common short case that you get at the exam also. And as an HO, you need to know how to assess whether intercostal tube is working, whether it can come out, whether it needs to be readjusted, all these things. So you need to know how to assess and examine a patient who has an intercostal tube. As a group, you need to discuss this. And as a group, you can send me your assignment. So it's just a one thing that you will have to discuss as a group, and all 50 of you can submit a single answer for that. This last thing is very important. You need to learn and practice the sterile technique of urinary catheter insertion. That is something that no one will be able to teach you as a group. You will have to do that individually. Don't experiment on patients. Remember, these people are allowing you to learn from them for free, right? And exposing themselves to any complications that you create for them. So that's a big responsibility on you as learners in this environment, right? So make sure that you learn how to insert it properly. All of you need to be able to do this at the end of your MSGOP, so that during your other appointments, you know how to insert a catheter safely. Right. So that's all I have to talk about today, right? Like I said, you have to practice this in order to get used to it. Do you have any questions?
So how can we remove the T-tube?
That's a good question. Now, your worry is that when you remove the T-tube, there will be a hole in the bile duct, and that it will spill the bile into the peritoneal cavity, no?
Yes, sir.
Yeah, so that's a problem.
And with that T-shape, how can we get it out?
Yeah, so that's a good question. So this is what your worry is, right? So, right. So your first issue is when you pull the tube, there will be a hole here. There's a space here, and there will be bile spilling into the peritoneal cavity. The second question is, how will it come out with this shape, right? So to answer your second question first, this is a very flexible tube. So the two ends will just bend and it will come out. Okay. Sometimes, I didn't want to mention it, we also cut this tube even further to make sure it comes out easily. Now this is a complete tube, no? You can even, sorry, now this is a complete tube. Right, so this is a complete tube that you have here, right? And then you have the other bit of the T going that way. Let's just erase. Yeah. Yeah. Sorry, I'll need to take some time to do this slowly. Right. Right. Okay. Now we can cut the tube like this. You understand? We can
Yes,
cut the tube so that only half of it remains. And that can make it easier to bring out. So we can cut the tube like this. Okay. If we do that, then problem sorted, and yeah. Yeah, we can cut the tube like that, and then we have only a gutter. That gutter is enough for us, right? To do the job. Okay, that gutter is enough for us to do the job, and then when you pull the tube, it will just turn into a Y shape, right? Like that. It will just turn into a Y shape like that, and it will come out. That's your first question. Second question. First question is, what is going to happen? Is it going to spill bile from here? And that's an interesting question. That brings us to another concept that we have in pathology, which is a fistula. Okay, what's the definition of a fistula? Anyone?
Connection between two epithelial surfaces.
Good. What is it lined by?
Squamous epithelium.
No. A fistula is a connection between two epithelial surfaces, which is usually lined by granulation tissue, right? So now here we have one epithelial surface, the skin, right? Here we have another epithelial surface, which is the bile duct. If you leave the tube here for a week or so, what happens is this whole area in between the two, right, gets lined by granulation tissue, right? And that's what we are hoping will happen. This whole area gets lined by granulation tissue, right? And also remember, okay, this is a question from anatomy. How much air do you have in the peritoneal cavity? Anyone? 1 milliliter, 10 milliliters, 100 milliliters. How much air do you usually have in the peritoneal cavity?
No air in the peritoneal cavity.
Good. Now, when we do a laparotomy in a patient and you cut the abdomen and open it and see inside, right, the appearance you get is completely deceiving. That is not how things are. All those bowels, the liver, everything is packed together without a drop of air. No space at all. No fluid either. Can you visualize that? Okay. There is no actual space in the peritoneal cavity, right? Like this. There is no space like you have here. There are no spaces. This will be plastered to this, or sometimes a bowel loop or something will come and it will stay here, something happens. So a few days after the surgery, all the air in the peritoneal cavity gets absorbed, the bowel loops readjust, momentum, all those things come back, and there is absolutely no space here. And then from here to here, right, and from here to here, you get this whole area lined by granulation tissue, right? This whole area gets lined by granulation tissue. So what have you created when you keep a T-tube for a week or two?
Fistulas.
a fistula.
Yeah, we have created a fistula. We have created a path connecting two epithelial surfaces that is lined by granulation tissue. Then it's safe to pull the tube out, right? And then nothing happens. If a T-tube falls out within the first few days of it being inserted, none of this has had time to happen. Then you have to do a laparotomy in the patient again and put the tube in again. Right, good. Any other questions?
Excuse me, sir.
Hmm?
Sir, if the bile gets coming out via the tube for a long time, so how can we make sure whether there is any stone in the common bile duct other than doing the tube cholangiogram?
Only the T-tube cholangiogram. That is the most accurate way that you have. Okay. If you leave the tube for a very long time, right? Some people, sometimes you can pull the tube out and put a small endoscope along that pathway and have a look also. That is done sometimes. But to do that, you have to take the tube out. No, once you take the tube out, you can't put it back in. So if you want to see whether there's a stone, the most sensitive, most accurate way is to do a T-tube cholangiogram. If you find a stone there, sometimes you can put a scope or something along the path after taking the tube and use that endoscope to break the stone or do something like that. But to diagnose a stone in that, the most accurate way is the T-tube cholangiogram. Any other questions? Good. It's good that you guys have questions. You have to keep asking questions, right? If not, this is not something that you can kind of wrap up by yourselves. And if you learn to work in groups, you will find that it's much more efficient than learning alone. All right, we'll stop there then. I will send a link to the coordinator in the surgery department so that they can check on, give you the link to Moodle if you want to go through this again. And go to the ward now and make sure that you try to go through these assignments. In about a week's time, it's good if you can give me these first three things separately and as a group discuss and tell me how you would assess a patient with an intercostal tube. The other thing of course is just a practical that you have to keep doing. All right, we'll stop there then. Thank you.
Thank you, sir.
Thank you, sir.